This brings us to Module 6. I've designed this module to specifically address what the general healthcare worker should know about postpartum hemorrhage. It will be a little bit repetitive from the prior modules. And I would also say, if you're just starting with Module 6, I do really believe it's worthwhile going back and listening to the prior modules because they have components in them that are applicable to all levels of medical expertise. So let's talk about obstetric hemorrhage in general. Again, to reiterate, postpartum hemorrhage does remain a significant cause of maternal death, even though we've had vast strides over the past 10 or 15 years in decreasing maternal death secondary to hemorrhage. We do have some ability to predict which patients are more likely to have postpartum hemorrhage based on their history and how their clinical picture is going during labor and delivery. Having said that, there are certain cases where we didn't see risk factors and postpartum hemorrhage can develop. I think it's critical to have some sort of standardized treatment algorithms and checklists for managing maternal hemorrhage that are specific to your healthcare facility in order to optimize your patient's outcomes. Patients at risk for postpartum hemorrhage, I just wanted to take a minute to review that so you know what you're looking for. Anyone who's had a prior history of hemorrhage around the time of labor and delivery, if they have an abnormal location of the placenta, meaning it's over the os or the opening of the uterus where the child's going to be born and the child would go through the placenta as it's being delivered, have a very high likelihood of major hemorrhage. In addition, if they've had prior cesarean sections and they have an abnormal placement of placenta, they could have what's called an accreta, and you may want to transfer them to a higher level of care for the time of their labor and delivery. Significant pain or bleeding during labor could signify abruptions or uterine rupture. If you already know they have a clotting abnormality or a history of difficulty clotting their blood, they would be at risk. Products of conception that remain in the uterus after the placenta is delivered can prevent it from fully contracting and also lead to hemorrhage. If there's injury or trauma from the birth to the surrounding vaginal tissues, such as lacerations or tears, they can lead to hemorrhage. Overall, the primary cause of postpartum hemorrhage is from uterine atony, which means lack of uterine tone after the placenta is delivered. To prevent postpartum hemorrhage, there's a variety of medications that can be used to help the uterus contract after birth, specifically the use of oxytocin, at least 10 units intramuscularly, or often if you have crystalloid available and intravenous line, you can dilute it in a liter of crystalloid, 20 to 40 units, and administer it that way. Standardizing cord clamping times and controlled cord traction to deliver the placenta and prevent the cord from tearing. Keeping an eye on how much blood loss is going on in the most objective manner that's available. And probably most importantly, watching vital signs during labor and delivery and after delivery, because often the blood pressure decrease is only one of the last things that we see in hemorrhage. And it's really that increase in cardiac rate and heart rate that is the first sign, and it would be the time that we want to get additional help. So as soon as you recognize there's some sort of postpartum hemorrhage, get help as soon as possible. Think about escalating the level of care. If available, think about invasive procedures to stop the bleeding, like an intrauterine balloon or some other surgical procedure. Or, if possible, think about transferring that patient to another location where maybe these resources are available if you feel they're stable enough for transport. If you have the ability to transfuse blood products, giving them in set ratios to minimize the chance of coagulopathy or difficulty clotting the blood. And I think it's worth 2 or 3 minutes to just go over the recommendations generally from the World Health Organization. Again, This should be updated later this year. It's anticipated the new recommendations were coming out in 2017, but all I have available is the 2012 recommendations. I encourage you to download this. It's free, and they will go into more detail, but I've just summarized the recommendations in general. So, use of uterotonics, the WHO feels that you want to proactively use uterotonics, specifically oxytocin. 10 units is recommended in all births, intramuscularly, or again, as I mentioned, you could give it intravenously. If unavailable, you could use other medications listed here, from ergotamines to oral misoprostol. If skilled attendants are not present and oxytocin is unavailable, then misoprostol is the recommendation by the WHO. And even in cesarean deliveries, oxytocin is sort of the standard of prevention. As far as management of the third stage, if skilled birth attendants are available, controlled cord traction is recommended at vaginal births, and this has been shown to create a small reduction in blood loss. If skilled birth attendants are not available, it is not recommended for cord traction for fear the cord could be torn. Late cord clamping, defined as anything after 1 minute, is recommended for all births to improve the status of the newborn. Early cord clamping, consequently less than 1 minute, is not recommended unless there's an issue with the neonate and they need immediate resuscitation so that they can be handed off to appropriate care providers. Sustained uterine massage is not recommended. Less, 15, 30 seconds is all that's really needed to help reduce postpartum hemorrhage in most women. And at cesarean section, again, it's recommended for controlled cord traction. If intravenous Pitocin is unavailable once you're already in a postpartum hemorrhage, then you want to move on to other uterotonics such as ergotamines or misoprostol or prostaglandins. If you're in a hemorrhage, there is no benefit to using colloids before crystalloids, at least initially. Ideally, you would be moving on to blood products if available shortly if the hemorrhage continues. Tranexamic acid, we touched on the prior module, but it's recommended only if oxytocin and other uterotonics fail to stop the bleeding. Uterine massage can be used for longer periods of time if the patient is actively hemorrhaging postpartum. And if the patient does not respond to pharmacologic agents to help tighten the uterus, intrauterine balloon is recommended. If other measures fail and available, a uterine artery embolization is recommended. And if bleeding does not stop, despite all these interventions that we've talked about, it's time to move on to other surgical options. This could be ligation of vessels. They talk a little bit about external aortic compression due to uterine atony if you're not using a surgical approach, or to buy time until appropriate care providers are available. You can use bimanual uterine compression as a temporizing method also until appropriate care arrives. Anti-shock garments are recommended to temporize. It is not recommended to pack the uterus. Again, we do want to use uterine balloons, but not just pack gauze or other sponges in the uterus because it may further create uterine atony. If the placenta does not come out spontaneously, it is recommended that you could use oxytocin to help expedite the third stage or delivery of the placenta. Use of ergotamine or prostaglandin E2 is not recommended for managing the retained placenta. It is recommended to give antibiotics if manual removal of the placenta is needed. And finally, organization of care. Again, the WHO recommends use of formal protocols, having them in place at the health facilities, ability to refer women to a higher level of care if it's unavailable at that facility, use of training and simulations to help improve the care in these crisis events, and then keeping your own data on use of uterotonics and prevention of postpartum hemorrhage as an indicator of how things are going at your facility. Thanks.